One of the more frequent reasons for seeing a cardiologist, of course, is complaints of chest pain. In fact, that is one of the most common referrals to cardiologists, both in offices and in hospitals. Chest pain can be due to a variety of causes. Of course, coronary artery disease or atherosclerosis is one of our primary concerns initially when we're evaluating a patient for chest pain. But certainly chest pain could be musculoskeletal, could be due to anxiety. Chest pain could be due to reflux. Chest pain could be due to even pleurisy or a viral inflammation around the heart called pericarditis. The evaluation of a patient with chest pain involves taking a very detailed history, performing an EKG, reviewing the past medical history and the risk factors for heart disease, and then proceeding with testing. Testing often will include echocardiography or, more importantly, stress testing. There are various types of stress testing that can be performed on a patient, including a regular treadmill stress test, a stress test using echocardiography to visualize the heart without injecting any radioactive isotopes, and then the more traditional way is nuclear exercise stress testing. In addition, some patients can't walk on a treadmill, and a stress test can be done artificially using a vasodilator, which is then followed by an injection of a nuclear isotope. In terms of chest pain, I do need to discuss one important matter, and that's the type of chest pain that would warrant an immediate visit to the emergency room. Any patient experiencing a heaviness, an oppression, traveling down their arms or to their jaws associated with breaking out into a cold sweat or feeling very short of breath or feeling nauseous, those patients should go immediately to the emergency room, because that could be a sign of a heart attack, otherwise known as an acute myocardial infarction. In cardiology, there's an expression, time is muscle, and if somebody's having a heart attack, we need to stop it as soon as possible. The ways of stopping a heart attack or treating a heart attack are to give a clot-busting agent or to send a patient to the cardiac catheterization laboratory and perform an emergency angioplasty and stent. Let me discuss the risk factors for heart disease. The four major risk factors for heart disease are smoking, high blood pressure, diabetes, and high cholesterol. In addition, there are other important risk factors, which include a family history of premature heart disease, and also obviously sedentary lifestyle, such as lack of exercise, obesity, and many other risk factors. Smoking is a very preventable risk factor. A family history of premature heart disease is not a modifiable risk factor. But let me just give you a quick definition of what family history of premature coronary disease entails. It usually is heart disease in a first-degree relative, such as your mother, father, or even a sibling, occurring before the age of 50 in a male and before the age of 60 in a female. The other major risk factors which I spoke about, including smoking, high blood pressure, and diabetes, are all modifiable. Of note, the incidence of heart disease and the mortality from heart disease has gone down tremendously over the last 25 or more years. This is due to many factors, including the reduced incidence of smoking, the use of drugs such as statins to lower cholesterol, and many other factors, including obviously better health care and better cardiac care specifically. Unfortunately, there's been an opposite trend over the last decade or more because of the rising obesity problem that we have here in the United States. Unfortunately, because of the increased incidence of obesity and diabetes, we're starting to see a trend towards a higher incidence of heart disease. And this is opposite to the trend that we had seen over the last few decades. Let me state also that the incidence of heart disease in women is actually very, very similar, and the incidence of heart disease in women increases after menopause, and 10 years after menopause, it's equal to men. In addition, the diagnosis of coronary heart disease is a little bit different in women. They present with symptoms that are not quite as severe or as intense as men. They oftentimes will not complain of chest pain per se, but will complain of shortness of breath or fatigue or very atypical features. This is now pretty well known in the cardiology community and perhaps in the general community, and I think nowadays most physicians and cardiologists in particular are very attuned to the fact that women may present a little bit more differently. One might ask when one should see a cardiologist. And basically, if one is experiencing symptoms of chest heaviness, chest pressure, fatigue, shortness of breath, it would be a good idea to see a cardiologist, especially if that patient had the risk factors or some of the risk factors for heart disease, which include smoking, high blood pressure, diabetes, and a strong family history of heart disease.